for providing the opportunity. Dr. Lalit, I think my topic is there a need for chemotherapy at all? Means is there more of an immunotherapy rather than the observation versus chemotherapy? Am I right, Sachin?
Yes, sir. So basically, wherever treatment is required, whether we can do it with chemo and use the novel agents.
So I don't think I'm going to talk on the observation.
Yeah.
Next slide, please.
Yeah.
No. Thank you, sir. We have moved with like the other diseases, myeloma, AML. I think the CLL also has got exciting. When we started journey, the chlorambucil and probably fludarabine, then the rituximab came in, then we used alkylator cyclophosphamide along with the fludarabine, and then we had FCR. Then in 2000, we had bendamustine rituximab. And after 2014, we have many molecules. We have a different mechanism of action, and the majority of them are oral. So we are in an exciting era. This is a treatment evolution which I have shown on this slide. Next slide, please. What is happening in treatment? The previous was the chemo immunotherapy era, where if you are a young and fit is the FCR, and if you are an older adult, either is a chlorambucil based combination or chlorambucil alone or rituximab bendamustine. In India, most of the people were getting treated with the rituximab and bendamustine. So probably very few with the FCR and very few with the chlorambucil. The majority were treated with bendamustine. Fortunately, the Ibrutinib is available and is available at a very low cost. Now we are in a targeted therapy era. The FCR is still for the young, fit, mutated one, except that all others have been moved to the targeted therapies. What we should do in India, I'll come to that. Next slide, please. This is, I'll show you the few guidelines we showed. And if you go through this, this proves my, what is my topic. But I will come that I may not agree completely with this. If you see a very small section, if you are a younger IgV mutated, one of the option is FCR. If you do Ibrutinib is fine. If you do a venetoclax is also fine. So apart from that, if you see all these era, they all are targeted therapies. So the Western world has moved, apart from the very small group, they all have moved to the targeted therapy. So the topic fits for the Western world. Whether this fits for our patients, I'll come to that. Next slide, please. This is NCCN guideline. So if you see a preferred regimens, even in a younger patients or the elderly patients, all are targeted therapies. So none of the preferred therapy is the chemotherapy. So if we go by this, the Western countries have moved to the targeted therapies. Next slide, please. What we should do it, I think we should do the test. Very important, wherever you're going to treat it, these three tests, if we can get it done, we should have it. FISH for 17p deletion. Very few people will have a p53 mutation. If we can do it, we should do it. Apart from this, otherwise, FISH for 17p and IGVH mutation status, we should know, because that will change the treatment algorithm. I think these two tests are must. The third one is desirable. So if we have all these three, that will help us to target the treatment. Next slide, please. Young fit, next slide, please, who are FCR eligible. Who are FCR eligible? So say if they write a 65 to 70, I will say, considering the all patients, even a younger ones, 30, 40 are getting with the rituximab, I think at least below 55, someone is IgV mutated, must be treated with the FCR. Why? If you see this pattern, there's a flat curve. So the 50% of the patients who are IgV mutated will have a flattened curve over the 15 years. So 50% probably are cured if you give them FCR. So below 55, not many comorbidities. You can extend it to 60. In our scenario, with the IgV mutation, the mutated one must be treated with FCR. That's my opinion. Next slide, please. If you see a FCR and bendamustine, so whether we can use a bendamustine, this trial has definitely shown that bendamustine rituximab is inferior to FCR. So someone who is eligible for FCR, we should not be using the bendamustine rituximab, which has been proven is inferior to FCR. Next slide, please. This has changed all the preferred, which says the FCR has not to be used. Is Ibrutinib and rituximab. If you see a 3 years progression-free survival, and this has shown an overall survival benefit. The Ibrutinib rituximab, though, is no less CRs, less MRD negativity, but the progression-free survival is significantly better than FCR, and even the small difference in the overall survival. Next slide, please. What I'm trying to say you, but if you see IGVH mutation, unmutated, what I'm talking is the 17p is out, the p53 is out. If there's someone who is not 17p, is not p53 mutated, has a IGVH unmutated, if you're a young patient, if you use the patient can afford it, want to have a long-term treatment with the oral medication, can use Ibrutinib. For someone who is mutated, I think because of the flattening of the curve, I'll prefer a mutated young patient fit for the FCR should be treated with FCR because there's not much difference between FCR and Ibrutinib. Next slide, please. And I'll come back to this, but before that, I'll go back to the elderly patients who are FCR ineligible. Next slide, please. Next slide, please. This is a trial. Every trial, the chlorambucil has been a poor arm. Everyone wants to have a FDA approval. Just do a trial with the chlorambucil and get approval. So this was a resonant trial, which definitely showed a significant difference in the progression-free survival and a significant difference in overall survival. Next slide, please. And if you see Ibrutinib, the most important is whether your IGVH mutated or unmutated. If you're using Ibrutinib, there is no demarcation. So if you are using Ibrutinib, and if you are whether mutated or unmutated, does not make a big difference. Next slide, please. This shows you the 5 years follow-up, and there is a significant difference in the overall survival in comparison to chlorambucil. Next slide, please. Whether the R-bendamustine is better is equivalent to the Ibrutinib. So this was a trial which shows that the Ibrutinib is better than bendamustine rituximab. Next slide, please. 3 arms: Ibrutinib with rituximab, and rituximab and bendamustine. This showed 2 messages. Rituximab bendamustine is inferior. If you are using Ibrutinib, probably rituximab does not have a major role. Ibrutinib doesn't mean that all the anti-CD20 antibodies will not have it, but if you are using Ibrutinib, probably rituximab is not required. Next slide, please. This is because this molecule also is available. This is the trial which was recent in ASH 2019. Acalabrutinib alone or with the obinutuzumab is better than the obinutuzumab chlorambucil alone with a combination of chlorambucil. Next slide, please. And this is the overall survival difference between the 2 arms. Next slide, please. Where will you use the acalabrutinib? If you see there is not much difference in the toxicity profile, but if you talk to the expert, they probably say is the lesser your cardiac events. Probably where you are the cost is not a problem, then you can use acalabrutinib if you are concerned about the cardiac event. Next slide, please. Apart from this, I don't see any major role of acalabrutinib. So Ibrutinib, very impressive progression-free survival in first-line setting in a younger patient as well as in the elderly. But the major problem is the indefinitive therapy. What we have learned with the CML people, we still see many of the patients with the blast crisis. If you have an indefinitive therapy, people will be very compliant in the first few years, and then they try to skip, and then they tend to skip that medicine, and we don't get the outcome the way it has been described in the trial. So lower CR, 30% at 5 years, and unlikely to have a MRD. Next slide, please. What is exciting in the first-line therapy? The time-limited therapy we would like to have it is 1 to 2 years. We have one molecule, it's venetoclax. Unfortunately, it's still not freely available. High CR rate and high MRD. Next slide, please. One of the exciting the trial is venetoclax obinutuzumab versus chlorambucil obinutuzumab. This was a time-limited trial. The venetoclax was used for 12 months, and then the subsequent follow-ups were there. So it's time-limited, had a high MRD and a very good progression-free survival. Next slide, please. If you see a significantly higher MRD rate, even with the chlorambucil, if you add obinutuzumab, you see a few of the CRs and MRD results. Next slide, please. This shows you the overall survival, the progression-free survival with the obinutuzumab and venetoclax. Next slide, please. What I'm trying to show you here is that there are two. Either you have indefinite therapy with Ibrutinib versus venetoclax with the obinutuzumab. The 3-year progression-free survival, in spite of using a 1 year of therapy, is being equal around 82% at 3 years. So at least till the 3 years, both the trials, in spite of having a limited therapy, probably the venetoclax is equal. Venetoclax with the obinutuzumab is equivalent to the Ibrutinib. Next slide, please. The long-term, the lifelong therapy, even the Western countries are going to accept it. So there are efforts for going for time-limited therapies. This venetoclax and obinutuzumab, which has been tried in elderly, probably will be tried in the younger patients also. And there's whether you can combine both the drugs, Ibrutinib and venetoclax, more MRD, high MRD, limited time of therapy, and more progression-free survival. Next slide, please. This has shown a very significant high MRD rate with the combination of Ibrutinib and venetoclax. I don't think that's an option for us, considering the venetoclax is not available. Even if we can try to get it, it will be very expensive. So even the Western world is looking for time-limited therapy. We also, I prefer to have a time-limited therapy rather than having a continuous therapy. But some people are willing for a continuous therapy. We would like to continuing Ibrutinib has become acceptable and is become accessible for us, which is a good news. Next slide, please. What I'm trying to say is, why not the issue is combine the only targeted. Why not combine a targeted therapy with the chemotherapy? Try to achieve a flat line, at least for the good risk group. So you have a time limited therapy, lesser side effect, and whether you can have a cure rate, you can have a 13, 14 years of flat line, whether we can achieve. So this is a MD Anderson trial where they have combined Ibrutinib with FC, rather not FCR, is FCG. So they have combined with the obinutuzumab. We cannot afford to do that. Whether we can have our own trial, combining these two molecules, combining with the targeted therapy and this one, and trying to achieve. So they have given only, rather than giving the 6 cycles of FCR, they have given a 3 cycles of FCG and Ibrutinib for a time period, the limited time. And so this looks lucrative, limited. Combining the chemotherapy gives us a flat line and high MRD rate. Next slide, please. And this is not for the bad group. This is for the good group. So the young patient, mutated, whether we can combine a targeted therapy with the chemotherapy, achieving that flat line and with a time-limited therapy. Next slide, please. This they have compared with the various other combinations of FCR. There is a one trial from Dana-Farber, is IFCR also. They use the 6 cycles. I will say reducing the some cycles and using Ibrutinib with FCR probably is possible for us, but we need to do a trial. We don't do a trials. We wait for the trials coming from Western world. Probably we may not get enough time limit, the lower number of cycles with IFCR. Next slide, please. So these are the pros and cons of the various types. Because of time limitation, I will not go through this. Next slide, please. There are certain advantages and disadvantages. There are certain differences in the responses with Ibrutinib versus venetoclax. I will not go through this. I think we all are aware of it. Next slide, please. And there are very exciting this. What we are saying, talking about targeted, even the control arms in the most of the trials have changed to the targeted therapy. So slowly the chemotherapy is moving out of even a controlled trial. So if you see many trials, even the control arm is a targeted therapy. So I think the majority of the people have moved to the targeted therapy. That suits to my topic, but probably is still not relevant for us. Next slide, please. So I summarize it. Chemotherapy is still important for Indian patients. Molecularly guided treatment should be encouraged. So wherever is possible, at least 17p by FISH and IGV combination should be done. We should have our own trials answering our needs. As I said, we cannot afford to have Ibrutinib, obinutuzumab, very expensive drugs. We probably have to have our combination. I will say we should have a combination, the combination of chemotherapy and targeted therapy, which looks to me as a promising. Thank you. Thank you, sir.